A patient rolls into the emergency department complaining of the absolute worst headache of their entire life. Their neck is incredibly stiff, and they are practically begging you to turn the overhead lights off.
Yeah, that is definitely a high-stakes moment at the bedside.
Right. So what is your very first clinical move? And what specific sequence of interventions are you anticipating the provider will order right away?
Every single second counts there. Your clinical judgment has to be razor sharp because recognizing those subtle clues changes the entire outcome for that patient.
Welcome to the Super Nurse Podcast, created by Brooke Wallace. And for our new listeners, Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
We should definitely clarify right up front that we are AI hosts. We are not Brooke Wallace herself.
Exactly. But this entire conversation is built strictly from her real-world bedside knowledge, her clinical notes, and, her signature teaching style.
Our mission today is taking all that complex, kind of dense pathophysiology and translating it into the rapid critical thinking you need at the bedside.
Helping you bridge that gap
Yeah.
between just passing the NCLEX and actively saving a human being in the ICU.
Before we get into all the clinical pathways, take a quick second to subscribe, and you can also watch the video version of the show on YouTube. The link is right down in the description on our channel called Super Nurse AI.
So today we're talking about meningitis. We're going to cover the pathophysiology, the critical differences between bacterial and viral presentations, and the dreaded lumbar puncture.
Plus, we'll get into pediatric signs and what the NCLEX actually tests versus what you'll use on the floor.
But before we can treat the patient, we need to understand what is actually under attack inside the skull.
Right. So if we look at the core concept in plain English, think of the meninges as the protective bean dip layers of the brain and spinal cord.
The brain bean dip. I love that.
It works, right? You have the dura mater, the arachnoid mater, and the pia mater. Meningitis specifically is inflammation of the leptomeninges. That's those inner two layers, the arachnoid and the pia mater.
But how do the germs even get in there? Because we constantly hear about the blood-brain barrier, right? It's like this ultra-strict nightclub bouncer.
It is very strict, but some pathogens are incredibly clever. They use a Trojan horse mechanism to get past that bouncer.
Oh, wow. How does that work?
Well, some bacteria actually hide inside the body's own white blood cells. They hitch a ride directly across the barrier, completely undetected.
That is terrifying.
It is. And once they're inside that sterile environment, the immune system freaks out. It floods the area with white blood cells to fight the infection.
Which causes massive inflammation, right?
Exactly. The area gets so swollen and thick with cellular debris that it physically blocks the outflow of cerebrospinal fluid, or CSF.
And since the skull is a rigid box, it can't expand. That blocked fluid causes the intracranial pressure, the ICP, to just dangerously spike.
Yep.
The brain tissue gets physically crushed by its own protective fluid.
Which brings us directly to what you see at the bedside. Because of that mounting pressure, the patient's body starts sounding the alarm.
Clinical experience shows us that in adults, we rely heavily on the classic triad. You'll hear it called the 3 H's.
Headache, hard neck, and high temperature.
Right. The hard neck, or neutral rigidity, happens because the meninges extend all the way down the spinal cord. If the patient tucks their chin to their chest, it literally stretches those severely inflamed layers.
Ouch. So the neck muscles just spasm to stop them from moving.
Exactly. It's a protective mechanism.
Now, for the next generation NCLEX, there is a huge focus on viral meningitis too. They really want you to know about nausea, vomiting, and photophobia.
Yes, the extreme sensitivity to light. And that vomiting is so specific. It's often sudden, and it comes without any GI warning.
Wait, really? No nausea beforehand?
A lot of the time, no. Because it's not a stomach bug. The swelling brain tissue is physically compressing the vomiting center in the brainstem. Oh, wow. Okay, but what about pediatric patients? Because babies can't exactly tell you they have a headache.
Babies present totally differently because their skull bones haven't completely fused yet.
Right, the fontanelles.
Yeah, so instead of immediately compressing the brainstem, that pressure pushes outward. You will literally see a bulging fontanel on top of their head.
That's a huge bedside clue.
Yeah.
And they also refuse to eat, right?
They refuse to eat, they're extremely irritable, and they have this distinct high-pitched cry. It almost sounds like a cat. It's a classic sign of neurological distress.
Okay, I have to ask about Kerni sign and Brzezinski sign, because nursing textbooks are obsessed with them.
Oh, they love them.
Kerni's is the pain when you straighten the leg, and Brzezinski's is when bending the neck makes their hips flex up. Are these actually reliable? at the bedside, or are they just NCLEX traps?
That's a great question. What we know from practice is that they are highly specific, meaning if a patient has a positive sign, they very likely have meningitis. But they have very low sensitivity. They might be completely absent in infants or in elderly patients because their immune systems just aren't strong enough to mount that massive reflex response.
So you can't just rule out meningitis because they don't curl up when you bend their neck.
Exactly. You have to look at the whole clinical picture.
Got it. Okay, so once you recognize these signs, the clock is totally ticking.
Yeah.
You have to figure out if it's bacterial or viral, because the outcomes are completely different.
Radically different. Bacterial meningitis is bad news. It is a highly contagious medical emergency with a very high mortality rate.
We're talking about bugs like Streptococcus pneumonia and Neisseria meningitidis, right?
Yes. And Neisseria often presents with this horrible petechial or purpuric rash. It looks like tiny bleeding spots under the skin.
And viral is the other side of the coin.
Right. Viral is very common, usually caused by enteroviruses or herpes simplex. It has a much lower mortality rate, and it usually just requires supportive care.
But because bacterial is so lethal, your absolute first nursing action when you suspect meningitis is initiating droplet precautions.
Immediately. You have to protect the staff and the other patients on the unit.
Brooke has this hilarious mnemonic for this. It's raining meningitis.
I love that one. Raindrops equals droplet precautions.
It makes it so easy to remember. Okay, so the patient is isolated. But to definitively prove if the enemy is viral or bacterial, we need to look at the battlefield.
We need a sample of the cerebrospinal fluid. The provider is going to order a lumbar puncture.
And the nurse's role here is huge. We verify consent, obviously, but we also have to make sure the patient completely empties their bladder first.
So important. The provider is going in with a needle near the lower spine. A full distended bladder is a massive puncture risk.
Nobody wants that complication. What about positioning?
The patient needs to be in a lateral decubitus position, basically a really tight fetal position on their side, or sitting up and leaning over a bedside table.
To spread the vertebrae apart, right?
Yeah.
So the needle can get in.
Exactly. But there is a major contraindication here that nurses have to anticipate.
Oh, the ICP issue.
Right. If the patient has severely high intracranial pressure, an LP is incredibly dangerous.
Because if you puncture the lower spine, you're creating a pressure release valve at the bottom of the system.
And all that high pressure in the skull will violently shift downward toward the low pressure. It can literally cause the brain to herniate down through the base of the skull.
Which is instantly fatal. So the provider will usually order a CT scan of the head first to make sure it's safe.
Always. Assuming it is safe, they draw the fluid. And the lab results give us a very clear picture.
I always like to think of the CSF like a fish tank.
Okay, I like where this is going.
So bacterial meningitis is like a cloudy, dirty tank. The pressure is high, the fluid looks cloudy because it's full of white blood cells, the protein is elevated, and most importantly, the glucose is super low.
Because the bacteria are alive and they aggressively eat all the the glucose in the tank.
Right. But viral meningitis is like a clear tank. Normal pressure, clear fluid, slightly high protein, but the glucose is totally normal.
Because viruses don't eat glucose, they just hijack cells. The food is left completely untouched.
That analogy makes it stick so well.
It really does. Now, after the procedure, the nurse has to keep the patient lying strictly flat, right on their back, for 1 to 4 hours. Some hospitals say up to 6 hours.
Why so long? Just to let the puncture site clot.
Exactly. If they sit up too soon, gravity causes that precious CSF to just leak right out of the puncture hole.
Which causes a massive debilitating spinal headache.
It is agonizing, so the nurse will keep them flat, push lots of oral fluids, and actually give them caffeine.
Wait, caffeine? Like coffee?
Yep, or IV caffeine. It constricts the blood vessels in the brain and helps replace the lost fluid volume to fix the headache.
That's fascinating. Okay, so let's say the fluid is drawn and the lab confirms it is bacterial meningitis.
This is where you have to act fast.
The nurse has to anticipate the provider's orders and execute them in the exact right sequence to literally save the patient's brain.
The sequence is non-negotiable. Step 1, draw peripheral blood cultures and send the CSF cultures. Step 2, administer steroids, usually dexamethasone. Step 3, broad-spectrum antibiotics like ceftriaxone or vancomycin.
Okay, hold on, wait. Why are we giving steroids before the antibiotics? I mean, shouldn't killing the bacteria be the absolute first priority?
It seems backwards, right? But here's the bedside logic. When those powerful antibiotics hit the bacteria, they slaughter them. And those dying bacterial cells release a massive amount of toxins.
Oh, so the body reacts to the toxins.
It overreacts. It triggers a massive, deadly explosion of brain swelling. The cure can actually cause fatal brain herniation.
Oh, wow. So the steroid goes in first to act like a fire blanket.
Exactly. It suppresses that inflammatory explosion before the antibiotics drop the bomb.
That makes perfect sense. Wow. And while all these meds are infusing, we have to manage the physical room, right? Create a neuro-friendly environment.
Yes. Dim the lights for the photophobia. Keep it incredibly quiet. And initiate strict seizure precautions.
So padded bed rails, having suction set up and ready to go.
Yep. And keep the head of the bed elevated to 30 degrees.
To help the venous blood drain out of the head.
Right. And you have to constantly remind the patient not to do any Valsalva maneuvers.
So no coughing, no sneezing, no straining for a bowel movement.
Nothing that increases pressure in the chest because that backs up right into the brain.
So to quickly summarize all of this for everyone listening, you want to spot the 3 H's: headache, hard neck, high temperature, and keep an eye out for those pediatric signs like the high-pitched cry.
Isolate them immediately with droplet precautions. Remember, it's raining meningitis.
Know your lumbar puncture positioning. Field position going in, strictly flat going out.
Look for that cloudy, low-glucose CSF to identify the bacterial emergency.
And always draw cultures before giving antibiotics, but get that steroid fire blanket on board first.
I really hope everyone listening feels like, okay, this matters, but it actually makes sense now and I can use it at the bedside.
Because understanding this isn't just about passing the NCLEX. This is real pattern recognition that will literally save a patient's brain in the ICU.
Before we wrap up, I want to leave you with one final kind of provocative thought to mull over.
Oh, I like these. Lay it on me.
Think about the anatomy of the head. Something as simple as an untreated sinus infection, a bad tooth, or a minor ear infection is sitting right next to the brain.
Wait, so those can cause meningitis?
Absolutely. They can erode the bone and create a direct highway for bacteria to completely bypass the blood-brain barrier.
Oh my gosh. It completely changes how I will look at everyday simple infections on the floor. A bad toothache could literally turn into a brain infection.
It absolutely can. It just goes to show how connected everything is.
That is wild. Well, thank you all for joining us on the Super Nurse Podcast today.
Yes, thank you.
Don't forget to subscribe and definitely check out the video version of this on the Super Nurse AI YouTube channel. We'll catch you next time.